welcome to our 5th episode of Clits and Coffee. I'm Melanie, a pelvic floor physical therapist.
And I'm Zoe McPherson, a pelvic floor physical therapist. And I'm super excited and very thankful that I have my friend from college, Nikki, here. And so I'm going to let her introduce herself.
Sure. Hi, I'm Dominique or Nikki. I'm really excited to be here. Love your episodes. And I am an OBGYN. I am what they call a generalist, so I do OB and GYN.
Okay. Well, yeah, we're really excited to have you and really excited for this episode today. So first, we'd love to get a background of your role as an OBGYN, what type of setting you work in, and what type of patients you see.
Sure. So I am, like I said, a generalist OBGYN, so that means I still do OB and GYN. I take care of pregnant individuals while they're pregnant, as they're delivering, so I deliver babies, and then in their postpartum period after they deliver. And then for gynecology, we kind of have 2 roles. The first would be, or I should say 3 roles. The first would be like well visits, where we're just doing health maintenance and things like that, like your pap smear, and then problem visits, which would be if you had any other issues that you come to your OBGYN for, like pain or bleeding. And then we also do surgeries, hysterectomies, if you have an ovarian cyst, if you wanted to have your tubes removed, things like that. And that's sort of the breadth of what a generalist OBGYN does. What else did you ask me? Where I work?
Like
what kind of
institution?
Right.
Yeah, what type of setting?
So I work as a generalist, I have both an office where I see my patients, and then I work in the hospital, both on labor and delivery, where we deliver patients, in the emergency room for patients with pregnancy and gynecology issues, and also in the operating room. And I work at what we call a big academic center, which means like a large hospital with all the specialists that you can imagine and lots of resources and research.
That's amazing.
Yeah.
So how many days are you like in the clinic versus in the OR?
Yeah. So that's definitely unique to every single person in OBGYN. We have a lot of different iterations of that, but for me, I'm in the office 2 days a week, and then I'm usually in the hospital 3 days a week. And then we see, patients who are assigned female at birth, both for their general OB and GYN care. So.
Great.
Yeah, and I think a big thing for me as a pelvic floor PT, and just hearing the other side from someone who's also doing pelvic exams, is when you go into like your general women wellness visit for a pelvic exam, what is it that you're looking at? Because we, in a previous episode, talked about like what we're looking at, so we can talk about kind of the differences.
Yeah. I think that's a really great question, because I think it's a mystery to a lot of people, including other doctors. So I will say that when I first started training, we used to say I'm going to use terms that maybe in some places would be vulgar, but they're medical terms. We used to essentially we'd say blow by the vulva. We wouldn't even look at it. We just put the speculum in. And then you started to realize that there's a lot of important information about the outside of the vagina called the vulva. And that's actually where my own interest and specialty lies. So when I'm doing an exam, the first thing I do is I inspect the outside, take a look at the labia, the skin, all of that. And then when I go to put the speculum in, I look at the opening of the vagina or the introitus, and then I'll put the speculum in. I'm looking at the tissue. So I want to see if it looks healthy, if it looks like it has been fed well by estrogen, if there's any prolapse or collapse of the vagina, and then if I see any lesions, discharge, anything like that. And then, of course, I always want to look at the cervix, which I always explain to my patients is like a shiny donut at the top of your vagina, to see if I can see anything with the naked eye that looks abnormal. That's where we collect our pap smear. And then as I take the speculum out, we have clear speculums, which is really great, so you can kind of see. So I kind of remove it slowly. Mm-hmm. If I saw any of that collapse, then I might do an evaluation for prolapse, which would be that bladder dropping or something. I know you guys know this, but and so I might take the speculum apart and kind of redo parts of that exam and have patients bear down to see if they have any findings of that. That would be the speculum portion of the exam, and then I do the bimanual exam. And so the first thing I do usually is I do a pelvic floor evaluation, which I feel like is just hilarious, saying near you guys. And then I will palpate the bladder as well, touch the bladder to see if patient has if I can elicit any pain there. And then I'm looking just for tenderness in any of your cervix, your uterus. When I touch it, is your uterus a normal size, a normal shape? And then I feel like the tubes and ovaries as well. Most of the time, in most people, you shouldn't be able to feel them, especially if they're postmenopausal. You should feel nothing pretty much. So if I feel anything, then I'm thinking, okay, something might be enlarged. And that's pretty much it.
Okay, that's great. And then, so are you ever looking at specific muscles of the pelvic floor?
Not knowing. Yes,
Yeah,
it doesn't get very specific. It's
Okay,
a very basic sort of just feeling the area. Both, I guess how I would explain it is I'm feeling for consistency. Does it feel like a tight muscle or lax? And then do they have tenderness when I touch it? And then sometimes if I notice one or the other, maybe they're coming with symptoms that are concerning to me, I might have them contract those muscles or do a Kegel exercise or something for me to assess, does it seem like they have any control down here, just so I can give someone more information.
Right. Well, and I think it is interesting, like listening to your gynecologic exam is we're looking at a lot of the same things. We look at the vulva, but we're, a lot of times we are looking and palpating different areas for, muscle tenderness to see if that's reproducing symptoms. Mm-hmm. If we're looking around the introitus, we're, assessing, flexibility. Is this a tight area? Is this not able to, stretch the way that we would expect it to? Because that can contribute to things like pelvic pain. Yeah. And then same thing with our internal portion of the exam. Our focus is really the specific muscles that could be contributing to some of their symptoms, in addition to their quality of, can they contract, can they relax, what happens when they bear down, so that we have more of that information for how best to treat them.
Yeah. It's interesting that you say that, because I think that part of that happens if someone comes to me with a problem or a symptom, and then I'm looking for those things specifically, but sometimes my brain isn't really looking for that. Or for example, if I notice when I go to insert the speculum that someone jumps, I ask them, did that hurt? And I always tell patients, the speculum exam should never hurt. You'll feel pressure, it's uncomfortable, but it shouldn't hurt. So if it hurts, let me know. So then when they have that pain, that will kind of prompt me to maybe do a little bit more of an evaluation.
That makes sense.
Yeah.
And I do think the biggest, like she said, the biggest overlap is probably the vulvar exam, which we're looking to see, are there signs of maybe changes in estrogen, which as pelvic floor PTs, we can't really make that diagnosis, but we know what that would look like. And that's going to be I'm going to refer you back to your provider so that they can look and see if it makes sense to give you a prescription for a gel. And so we're looking at that same thing. But then you mentioning palpating the uterus and did you say that your it was the uterus and obviously the cervix and the ovaries. I'm in my head I'm do you have a speculum in while you're doing that?
No.
How the heck do you palpate the fallopian, the ovaries with I don't even actually know what that looks
It's a
like.
great question.
Because I feel like this is something that we probably could do, but it was because they're not muscles.
Right.
We're not taught at all what that feels like, and so I think it'd be super helpful to know what a red flag would be.
Right. Yeah, very true.
Yeah, so I'm not sure what your pelvic exam entails necessarily, but they call it a bimanual exam because you're using both hands. So we use our 2 fingers typically, unless someone's really sensitive. I don't really need to have 2 fingers in there to basically get under the cervix, and then I'm using my other hand on the abdomen. So when I'm feeling what we call the adnexa, which is the ovaries and the tubes, I go to one side, I'm feeling up next to the uterus with this finger, and then I'm pulling this hand and I'm almost feeling between them, and then I do it to the other side. And if I can feel a fullness there, for example, then I know there's something there that probably is not normal. Doesn't mean that it's something necessarily bad, but usually it means there's a cyst or maybe a fibroid associated with the uterus or something like that. So it's really almost like a squeezing between, and you should feel nothing. You should almost feel your fingers touching. And when you feel something that's moving with your hand or a fullness there, then it's a finding.
Yeah.
Mm-hmm.
Which now, like, I'm thinking
Yeah.
about Mel and I are signing up for a visceral mobilization course. And I'm like, I hope we get this because
Right.
that would be, like, I mean, so many people who come to us, like, have fibroids or a history of fibroids. And if, like, there's a screen that, like, I find something abnormal, like, immediately I have a very concrete reason that's not just the symptoms that they're telling me to go refer back.
Mm-hmm.
Right. Well, and, I mean, it is fascinating. Like, you really need that extra hand to almost like
Yeah.
pull
Yeah, you
structures
do.
closer to you. That's really fascinating.
Yeah. It also helps too because we can distinguish between if they're having pain with, I call it my internal hand or my external hand. So is it really abdominal pain or is it actually associated with the organs that I'm most interested in? Because a lot of times you can do your bimanual exam, but anyone's going to feel discomfort when you do that. So really trying to isolate when they say they feel pain, do you feel it with my hand on the inside? Because I'm actually touching those structures with that hand.
Right.
The outside is just helping me kind of manipulate it and get more information. So.
Well, yeah, and that actually, so one of our big things that we wanted to talk about was, so based on your exam, like, when do you know, like, okay, this is something that needs to be managed medically versus, you know what, maybe I need to refer to something like pelvic floor or physical therapy?
I will say that I usually err on the side of referring to pelvic floor if there's any pain component for sure, unless it doesn't seem like it's really pelvic at all. Mm-hmm. People providers and patients alike sort of generalize the abdomen and pelvis and just say like, I have abdominal pain, and sometimes it's their bladder and sometimes it's up here, and so if I can isolate it to that area, I will usually err on the side of that if I don't think it's really attributable to anything else. But things that would really make me feel like they're actually going to benefit from it would be if I do find that the patient is tender when I do that exam of those pelvic floor muscles, of which I do not know the name. And I'll literally describe in my referral, I'm like, on the left, distally, like near the opening. It's like, you'll know what I mean.
You'll figure it out. It's
if
fine.
they have tenderness, or if they have a symptom they're coming with and it feels much tighter on one side than the other, like more than I'm used to, that's something that I definitely send them. I was telling Zoe about a patient that I felt like was like a real victory that came to me, had this basically, like at that point, chronic back, hip, and pelvic pain, had been seeing her PCP, had seen another gynecologist in my office who ordered an ultrasound that was normal. Essentially, they were like, take Tylenol, take Motrin, it should go away. Her imaging was normal. Well, I was like, okay, the way she was describing to me, it's all on the same side. I'm like, I'm gonna feel your pelvic floor. And she jumped off the table when I even just touched the muscles on that side. And I asked her, I said, did that cause the pain that you've been feeling? And she said, yes. And I was like, oh my God, well, I think the good thing is I have an explanation probably for at least part of this pain, right? And so those are the things I really look for. Other reasons that I would send someone would be if they have like urinary incontinence and they're having leakage, and I can tell from my exam or their history that it's something that might be helped by pelvic floor PT, or I know that a urogynecologist, which is a specialist in gynecology that I would normally refer them to, is going to refer them to pelvic floor PT anyway. I'll try to refer them to both at the same time. The only time I wouldn't do that is if I think maybe they're going to be taken right to surgery and the pelvic floor PT may not help necessarily. Then I kind of try to prioritize, something else, and then maybe they can determine if they think ultimately it would help. And then finally, any postpartum patient I think could benefit from your evaluation, so I try to encourage them all to go. But I explain to them, like, you don't have any problem right now, or if they do, then I'll talk to them about that. But and I really encourage it. But I'll say, like, this is just going to be an evaluation. Maybe they can talk to you about preventative things. So
yeah.
But I love you guys and what you do. I wish there were more of you.
I know you're in like a very poorly represented area for pelvic floor PT, whereas like we're so lucky in DC that there's tons of us,
Right.
like tons.
Right.
So it's a bummer because it's probably a really long wait, and I apologize. My dogs are getting a little crazy. Xena, that's enough. And so it's just got to be hard because like it's almost like maybe you have to pick and choose because most people probably aren't going to get in.
Right. Yeah.
And so like if you do find pelvic floor discomfort, or you find that someone maybe has some laxity or weakness, is there anything that you like in the interim would do or give them, or handouts or exercises before they get into PT, or do you just wait and let the PT do that?
So I wish. I would say that at least right now in my practice, I do kind of let the PT be the source of that information. I do not have a handout, but you asking that question makes me think that I should call the people I'm referring to and ask them, is there anything you would want me to tell the patients before they get to you? Because, for example, I have not worked with pelvic floor PTs, but I have worked with some providers who do some of that work in their office, and they seem to all have different ideas about the best way to teach someone how to do a Kegel, and I don't know what's evidence-based, so I don't want to tell a patient the wrong thing and then them come to you and you have to undo the damage I've already done.
Yeah.
Or maybe with some patients, a Kegel is not a good idea for them and might actually not be helpful. So I've been deferring to you because that's sort of outside my current understanding and knowledge. But I think it would be helpful to get some education from the people I am referring to, and even have a handout that's endorsed by them with like actual real information. Right?
Yeah. We were like actually talking about this because, and I think the topic came up last night actually at dinner, where someone was like, I thought it was you and it was not, I guess. It was talking about like giving a Kegel handout, and it's actually not evidence-based to give a handout. So it wouldn't make sense to do. The evidence says that a handout is not a good way to teach someone. Mm-hmm. And then you're not figuring out like, is it attention? Are they doing it correctly? Are they gonna like what's going on? So I think a handout probably actually is not the answer unless it's like on breathing.
Yeah, that's what we were saying today. And yes, and we have this conversation all the time, is that, you know, a lot of times patients read online, or maybe they hear from another medical provider, just do your Kegels and you'll be fine. And then by the time that we see them, that's not what they needed, and they needed something completely opposite. They needed maybe more of a relaxation standpoint, and the Kegel, number one, wasn't making their symptoms better, could have been making them worse. And like, I think a lot of people in general, they want to get better faster, so it's not like they're just doing like 5 Kegels, they're doing like 300. Right. You know, they're like trying to do them all day long. And for a lot of patients with pelvic pain, oftentimes the Kegel is just contributing to more of that overactivity and more of the tension in the muscles, and contributing to their condition. Yeah. So yeah, I think it is important to not to just give blanket handouts to patients if there hasn't been an exam that they actually need, specifically like pelvic floor strengthening. But I do think handouts on, you know, we've talked about handouts on breathing is really helpful, or even just your pelvic floor PTs in your area, maybe just a handout on what it is and what they treat could be helpful. Like maybe not giving a specific exercise, but hey, pelvic floor PT can help with these type of conditions. If you have this problem, this would be a good place for you to go to get treatment.
Can I ask you guys a question?
Yeah.
So from an OBGYN perspective, I'd love to know who you think is appropriate for us to send to you, and I guess what evaluation or things that you would want us to recommend to patients before they got to you.
I mean, like, I think that, especially as a generalist, like, you're not supposed to know the pelvic floor eval. Mm-hmm. You can differentiate tension versus not, right? Like, that's all that matters. And our job is to assess the muscle. So I don't think you have to be good at a pelvic floor exam, but knowing tight versus not, right? Mm-hmm. Like, that's helpful. Because it doesn't change my exam at all. The biggest thing that I would say is like, right, anyone who has pain, postpartum, whether they have like a history of constipation, if they have chronic hip pain that aligns with tension on the same side, like things like that. And then anyone pre-surgery, so let's say they're gonna have a hysterectomy or they have prolapse and they're gonna have surgery, doing things beforehand to teach them body mechanics and breathing so that after surgery they're better equipped to reduce the risk of things later. I think that they're a good candidate.
That's so interesting. Now, is that like anyone who's getting a hysterectomy, or would you say people getting a hysterectomy for a very specific reason?
I think that's a little tricky, because obviously there are limitations to getting someone to a pelvic floor PT prior to surgery. I think that if it's available, I think it's super helpful to even have the conversation of what the expectations are after surgery too. Like I love seeing people before surgery, and it might be a one and done visit. We talk about what they can do leading up to surgery to get the hips strong, to get the back strong, get their core strong, like do some different general exercises that they can start before surgery, teach them how to breathe appropriately, have some awareness of their pelvic floor, and then say, okay, well, after surgery, it is expected that there will be some different things that you're going to have to work through. Talk about scar massage. So talk about things that they can do after surgery, and then have those sessions after. So I think the expectation part after surgery, that we have more time in our visits to go over, is really, really helpful and powerful for the patient.
No, I'm glad you guys mentioned that, because I think that's a real blind spot for me. I have not really considered any sort of pelvic floor issues that might even develop after surgery. I've never thought of it after surgery for my GYN patients as a preventative thing that I could do for that and offer to them. But also, even until right now, thinking about the pelvic floor issues that you could develop because of just post-op pain after a hysterectomy, where a lot of the pain is at the top of the vagina and in the pelvis, and how as they heal, they could be developing tension and things there that ultimately could lead to other issues. I had never really thought about that.
Or even after surgery, a lot of times, or with the scar that you have, a lot of times that can also lead to bowel issues, constipation, things like that, where okay, maybe after you've recovered from surgery, if you're still experiencing that, because maybe they are holding tension in their pelvic floor, which can lead to things like constipation, and that could be a musculoskeletal issue. So it's hey, be on the lookout for this, and if we need to refer you after, we always can. I think that it might have nothing specifically related to the surgery itself, but these other things might develop because their body has undergone surgery.
Yeah. And any other surgery, right? For almost any surgery, you're gonna get referred to PT. And sure that this isn't a muscular surgery, but you're going through muscle tissue to access it. So it's still going to be involved. There's going to be swelling. There's going to be inflammation. There's going to be muscle guarding. So there's always going to be a muscular component. And then that pre-op visit helps to give them an idea of why it's important post-op, and then build that rapport initially so that they're probably more likely to have follow-up. And they can get on the schedule then, right? They've already been seen, so they can schedule that for post-surgery, because they probably have their date. You see them, somewhere around 4 to 8 weeks post-surgery, depending on how they're doing.
And would you guys ever do an internal exam after a hysterectomy?
Only when they're cleared by OB.
Yes, that was gonna be my question. All right.
So as soon as they're cleared for penetrative vaginal intercourse or any sort of penetration, then we would do it. Or if I got an explicit written note from an OB that has been documented to say that I can do it before that.
Right, yes. We do typically, OBGYN does an internal exam before we would. We always do want that medical clearance and stuff.
I would do an external exam where I could see, can you contract, can you relax, is anything tender externally, is there anything that I notice here that we can work on, but it's not, and then we're not going internal.
Would you guys mind talking about your evaluation for people who have painful sex? I'm thinking more pain with insertion. So what we would call vulvodynia.
Yeah.
And usually vaginismus. Because I can do the evaluation in my office, and it does fall under something I'm really passionate about, and some of that can be skin conditions and things that I can treat, and low estrogen that I can recognize and treat. But when I can tell that there is a tension at the opening, there are certain things that I can do and certain medications that I can prescribe, but ultimately I can't actually solve the problem. And so I usually recommend pelvic floor PT.
Well, I think first, a really good subjective history is super important with painful intercourse. And one of the first questions that when we start getting into that topic is, is the pain upon insertion, or is it deeper penetrative pain? Because that can also change what our treatment may be, and also what we're going to be looking for on the exam. But yeah, I'll start with external. We do our external exam, just kind of like we talked about before, to see if there's any muscles externally that reproduce any of their discomfort. Because also, like, painful intercourse, we assume is going to be internal, but sometimes some of those external muscles can refer to the pelvis, they can refer to the hip. So also, we do want to do a thorough musculoskeletal exam externally first.
Do you mind if I interrupt there? Because that's something I definitely don't do as part of my exam. Is there a way that, as an OBGYN without physical therapy training, I could even, on like a global level, identify that? Because that might be something I'm missing if I do my exam and I don't find anything else, realizing that that is something you could do.
Well, I think the easiest, probably fastest answer to that is the Q-tip exam of the vestibule, right? Like if you're closer to the urethra and that's painful, that's probably more indicative of hormones. And then closer to like the 5 and 8 o'clock, that's where a lot of muscles are attaching. So if that's tender, it's probably more muscle tension.
Okay.
Of course, there's overlap. And so if you're doing the Q-tip exam and it's global, then it's probably both.
Right.
Which again, like I can't explicitly say like it is estrogen, but I'm going to refer back if it's more urogenital triangle. And then, I mean, just palpating externally, like at the pubic symphysis, and if we're looking like around, this is a muscle, right? This is ischiocavernosus. So if the labia majora are here, just outside it where you're feeling bone, that's a muscle. Like if you're pressing and you feel some bone, you're right on a muscle.
Okay.
And then you can come down, right, like just lateral to the perineal body, that's going to be a muscle. And so you can go on either side and you're hitting muscle tissue.
Yeah.
And then I think it gets a little bit harder for down here where I don't know if it's worth going into. But those are some good screening, because if they're having vulvodynia, these muscles are probably tight anyways, so that's already a good screen.
Right. Well, that's interesting because typically from a GYN perspective, we focus our Q-tip test and evaluation to the labia majora and literally the introitus, the opening, the urethra, etc. And I'll even, go in between the labia and things like that, but I would never even consider kind of going farther out and feeling that. So that's something I could add to my exam.
Super quick.
Just to say, oh, look, you're having pain here. I feel like that supports that you would benefit from a pelvic floor evaluation.
Right. Yes, absolutely. And then internal exam. So we, the pelvic floor muscle layers, there's 3 layers. And it's basically the level of your knuckle. So we want to be really specific as to what level is contributing to their pain. So that's like really getting specific. Like, is it just layer 1? Is it just initially upon insertion where it's just right up to the first knuckle? Do they have pain at that level? And then we can also check right and left side. If they have no pain at that, then we move on to second layer, right, left. Do you have pain? Does that reproduce your pain? If it doesn't, we go to third layer, which is the deepest pelvic floor muscle layer. And then that way we can also get really specific along like the pelvic wall. There's a hip muscle that attaches onto the pelvic wall, and we can actually feel around. Is there muscle tenderness in those areas, and is it reproducing their pain? So being really specific with, is it insertional pain or is it deep pain? And if it's especially deeper pain, where is it? Where is it along the wall? Is it on the right? Is it on the left? Is it globally? Is it all over? Because I think that kind of will dictate also what type of treatment we'll provide in terms of, do they need more muscle release techniques to specific areas, or is it really that like global vaginismus pain where they are just tense with something being inserted into the vaginal canal?
Because that's also very interesting, because if someone has pain to deep penetration, that is sort of a characteristic symptom of endometriosis. However, it doesn't always indicate that. And sometimes it can be the shape or position of your uterus. So if I can find something that's like a point tenderness behind the cervix and they have other symptoms of endometriosis, it makes me feel very confident that it's that. Or if I can feel the top of their uterus right there, I'm like, okay, you're coming in contact with that during intercourse, and that's why, and it's just positional. But I've never even thought about that pain with deeper penetration being anything that you could address as a pelvic floor physical therapist. So that's also great because I can't necessarily do a useful evaluation there, but I typically am not referring them to those things, and unless they also have back pain and hip pain or something else that I think maybe they're all contributing. So that's really good to know.
Well, what I just thought about was even people with endometriosis, they're still engaging in intercourse. They're still having penetrative sex. So yes, pelvic floor PT isn't necessarily going to change the endometriosis, but our treatment techniques can help, desensitize the tissue, help decrease the fear of, some of our treatments are designed to decrease the fear of something being inserted into the vaginal
Like
canal.
that anticipatory.
Right, exactly. Like you already have
response.
this fear response to that because it's painful. So can we even calm down the central nervous response, knowing that we're not going to change the endo, but knowing that this person still does want to engage in intercourse. Yeah.
So cool.
Yeah. Did you have anything to add to exam stuff?
No, I think that was.
Okay.
Sorry.
Oh. Pat on the back. She's okay.
No, I think and we do go into a lot of that in I think episode 3.
Yeah.
But
check it out.
From again a gynecologic perspective, something that we learn about is teaching for treating vaginismus really and dyspareunia or pain with sex is using vaginal dilators. I found a couple of websites that are pretty patient friendly and very they feel very clinical, so patients feel more comfortable going to them. But Zoe was telling me before how there are really specific ways based on your exam to use them to actually be effective. So what we learn is sort of especially if you feel a constriction of the tissue there, and a patient I can't even do an exam because I can't get a fingertip into the vagina because of pain, discomfort, or tightness, that we can have them sort of use it to just kind of stretch the area, desensitize the area. But I imagine there's so much more to it, and that's not something that I necessarily teach them. So is it harmful to have them do some of that simple work before they see you? Is that something you end up having to correct, or could you build on it and we could still recommend that to them?
I've seen it both ways.
Yeah.
Where I think I don't know it would be harmful.
Right.
I've seen people, I think the biggest thing is push through too much pain, and that could be harmful. But because there's a lot more to it than just the description on the handout, and it really can get more and more specific to the person in front of you. They can get started on it, and I've seen a lot of people who have done well, and then they're like, but I'm not better. I'm doing better, but I'm not all the way well.
I'm not best.
And so they'll wind up coming to me then, but if we could probably see them earlier, then that would be helpful. But also again, it's hard to get in with a pelvic floor PT where you are. So if they can get started, and the biggest conversation is if pain is above a 3, don't push through it. Change something, the size, your position, your breathing, to bring it down. And if you're not bringing it down, go down the size. And just emphasizing that the goal is not pushing through pain, then I think it's useful because they're probably not going to see someone for a while.
Right.
But I think that's dependent on where you are. In DC, they could get in pretty quickly with someone. So maybe it would be better to wait versus somewhere where it's harder to get seen.
But yeah, I think that's the biggest thing is the education of, we're trying to decrease pain, so we don't create pain while we're trying to decrease it. So pushing through to get, it's not going to get you better faster. You're better waiting for your body to respond to say, hey, it's okay. Right. It's okay to proceed with this dilator, this level, this depth. So I think that's the biggest thing is it wouldn't be harmful, but give that education of let your body know and respond the way that it's supposed to, and it will tell you by having less pain.
I mean, I think that was a lot.
Yeah. Do we have any other things?
I don't know, any burning questions?
Not at this moment. I basically hijacked the second half of the interview and asked you guys all the questions.
No, I like it.
Yeah,
I think
That
this is
have
like-
been burning in my heart.
Yes. I think it's just really exciting, just like different providers coming together for the same goal for our patients, working together. I think that is great, and I hope that continues to be the trajectory of healthcare.
Yes.
Yeah. And thank you everyone for dealing with my dog noise. We're not in our usual place where we can shut them out. So, yeah.
All right. Well, I hope you enjoyed the episode. Give us a listen, like, subscribe. If you have a comment or something you want to hear us talk about, please leave that as well.
All right. Bye.
Bye.